the Wellbeing Show. I'm your host, Noel. But if you're a regular, I've just bored you to tears already. You've had enough of me. Got a great guest on this evening, Perri Borish, who's joining us from the East Coast of the US, who deals with all things maternal mental health. So we're going to have a really, really interesting conversation about that. I'll introduce her properly in just one second. But before we get to that, just to encourage you to join us if you wish. The easiest way to get involved, it's a live show, and it'd be lovely to get your engagement and thoughts and questions. And I guess the easiest way to do that at the moment is drop me a line on the phone. My number's +44 7506 319 745. So jump in, send me a message on WhatsApp, and it'd be great to hear from you. Enough of that. Oh, actually, remember, this is a live show, so if you're listening to this on any time other than Wednesday between 9 and 10 UK time, you send me a message. I won't get it because I'll be doing something else. So if it's Friday morning and you're watching it as a download, I probably won't be able to answer you. Anyway, here we are. Perri, lovely, great to have you on the show. How are you?
Hi, I'm good. Thanks so much for having me.
It's great. I mean, it's a sort of one of the amazing things about the pandemic was this very frightening thing where we wanted to stay at home, but then suddenly we discovered this thing called Zoom. Like the whole world overnight discovered, oh, we can connect no matter where we are. So one of the unintended consequences, I don't think the virus was thinking of that when it popped into our lives, but it's great to have you with us. And you're in Philadelphia?
I am, yes.
There was something about a bell in Philadelphia, is that right?
That's right. That's right.
The Liberty Bell, is that correct?
The Liberty Bell, correct.
I've only seen in things like Shooter, the film, and stuff like that. But isn't that is it where you signed your constitution, or you thought it up? Or tell me.
They signed the Constitution here, yes.
That's right. So it's where the US officially started.
The founding fathers were all here.
Wow. Well, I sort of, do you feel the weight of that history on a daily basis? Not probably.
Yes, the weight of the founding fathers I feel on a daily basis.
It's me. It's good. Well, somebody has to, because it's quite a thing. Otherwise, it could be crushing. It's really, really good to have you with us. I know you're a busy therapist and mum, and so for you to carve some time out for us I'm really grateful for that, and join us. I'm sort of intrigued as to, having mentioned it, what the last, I suppose, 19 months have been like for you in regards to the pandemic, how it's been, and what your experience has been like.
Yeah, so I mean, it's been really interesting, especially as a therapist, to have a parallel experience to all of your patients, right? Because that almost never happens, where your patients are anxious and grieving and scared about the same thing that you're anxious and scared and grieving about. But it's certainly been the busiest time of my professional career. And in my practice, we have there's 6 of us. And so we've all been overbooked the entire pandemic.
Yeah.
And of course, it's been, I think with the political climate and the pandemic, it's been a particularly challenging time for mothers and pregnant women, and women going through fertility challenges as well.
Sure. Well, we're going to talk about some of those things, but I think it's really important that if people are listening to this to understand that as professionals, we'll talk about these things and the impact upon the work, but as professionals, we don't judge people on the basis of the views they hold. It's sort of, we're clinicians, we help people, that's it. But obviously, context, as you've mentioned, can at times have a significant impact upon what's going on. And I guess that's what you're talking about, is that there is a framing and experience that people bring into you.
Sure. And also what I'm talking about is that as clinicians, right? Therapists, I mean, at least in the US, are being asked to do all kinds of things in the pandemic that we're not normally asked to do, at the same time that we're also in a pandemic, right? And parenting or homeschooling, as it were.
Yeah.
And
so what are the things that you're talking about in terms of the things you're being asked to do? Are there the sort of new things, or just exactly?
Well, in a lot of smaller communities, I mean, not in Philadelphia, but in a lot of smaller communities, therapists are asked to, be almost play so many different roles, right? Be hospital social workers as well as private practice clinicians, help people through their fear, but also the grief, right? All of the people who have died, the mourning. In some places, be almost like police. And it's a lot to put on clinicians.
Yeah, in terms of almost like police, just tell me a bit more about what you mean by that, because I actually don't know what you mean. So,
well, I mean, earlier in the pandemic, right? Policing sort of how people were.
In terms of presentation for meetings, PPE and things like that, and the rules.
Right, all of that, like who can come in, who can't.
Okay. Yeah. No, I guess
right?
Absolutely.
Without having the structure of ethically or legally, how do we do this, right? Because normally we don't ask about vaccinations before seeing a patient.
Sure.
Right.
Sure. Yeah, I mean, I guess because sort of certainly here, I mean, I'm like you, I'm a licensed professional. I'm a licensed mental health professional. A lot of therapists in the UK are not licensed. It's very different. You're an LCSW, licensed clinical social worker. And just before people get confused, you are a therapist, and that's what an LCSW is. So social worker bit might confuse people in the UK because social worker is a different beast over here. So social workers are not therapists in the UK. They're case managers. They organise cases. They support clients in finding services, and they do certain statutory duties such as adult protection and child protection, and also in mental health terms, they have legal obligations sometimes as approved social workers to they can incarcerate people under the mental health legislation. So it's a sort of very different beast to the US. So just so that people understand. So we're talking to you in the capacity as a psychotherapist. And also you are influenced strongly by psychodynamic thinking. Yeah.
Yes, psychodynamic, yes. And my postgraduate training was in modern psychoanalysis, although I don't practice that.
Okay. So tell me the differences, which I guess I know, but tell us the difference between psychodynamic and psychoanalytic, and what you mean by psychodynamic and what that means in terms of your practice.
I mean, so psychodynamic is really, the way I think of it is really bringing the unconscious to the conscious and looking at the patterns, the coping skills, right, that we've developed over our lifetime, and how, and really the important part, and why we develop them and how they're not working anymore. And so we often have to go backwards. I mean, this is my bias, right? We have to go backwards to go forward, right? So it's in the understanding of where those patterns and coping skills developed that we can separate from them.
And psychoanalysis, is it the same? Is it different in your book?
No, I mean, psychoanalysis is, classic Freudian, right, therapy. It's psychodynamic therapists use the relationship between the therapist and the patient in a really profound way. We care a lot about transference and countertransference. We don't need to get into the definitions necessarily of those, although I can explain them if you'd like. But in psychoanalysis, the therapist is much more sort of, there's no disclosure from the therapist, right? It's much more about really the unconscious dream state, and they don't use the relationship as much. And often in classical psychoanalysis, you might be in treatment 3 times a week.
Okay. Which I think are probably shared understandings, but it's important to sort of make them clear. And sort of psychoanalytic method tends to use what's called the blank screen more, and you might find people being asked to go on a couch and lie down and not look at the therapist, and those, where psychodynamic wouldn't necessarily, you might use those techniques, but there's other techniques available. Like you say, it's about forming a relationship. Without getting too caught up in the technicalities of transference and countertransference, I think it is important to look at it in terms of relational-based therapies, because we're making subtle interpretations of our own responses as clinicians, which we then use to help us understand maybe what's going on for our patients. Now, I think there's an important context to look at, and I'm interested in your views on how much is present from outside when people come into the consultation with you, and how much in terms of sharing or not is important. I think you've begun to intimate that the pandemic has shifted maybe your perspective a little bit, just because there's been what we call a parallel process going on.
Mm-hmm. Do you mean for the clinician or for the therapist? I'm sorry, do you mean for the clinician or the patient?
I'm more focused on you, I suppose, and your understanding of the practice, and your explanation, and sort of we'll just see then where that conversation goes. But if you start maybe with yourself as as a person, as a clinician,
right,
your understanding of the work, and then let's just see where that goes. Is that okay?
Sure. So my specialty, as I think you mentioned, is maternal mental health.
Yeah.
And so in terms of, disclosure, right, or what you share with the patient, often when mothers come to see you, they want to know if you're a mother yourself.
Yeah.
Right. And they want to know that because they want to understand if you can truly viscerally understand the sort of the ambivalence of motherhood, right?
Yeah.
And unlike treating other things where you don't necessarily have to have that experience yourself in order to be a good clinician, with postpartum women in particular, it seems like it's a really big, it's an important component. I'm not sure if I'm answering your question about.
You are for me. Just so people are clear, I mean, you're talking about postpartum depression, and the complications that a mum might feel because they have these negative as well as, well, often quite negative feelings towards their new child, which counter the sort of societal messages that you should be able to bond, for example.
Well, postpartum depression is not necessarily negative feelings toward the child.
Yeah.
And I'm not.
And then how it impacts upon sort of maternal mental health when somebody does have that experience of postpartum depression, for example.
Sorry, can you say that again? You cut out.
Tell us more about postpartum depression then, the sort of range of experiences that somebody might have.
Okay, so it's perinatal mood and anxiety disorders is the spectrum of what can happen in the postpartum period, and actually in pregnancy as well. So a woman might have postpartum depression, she might have postpartum anxiety, she could have postpartum OCD, for example. I mean, there's a wide range of what she can experience in the postpartum period. I think my point was just in terms of disclosure as a clinician, my training is not to disclose too much, except that in the population, in this particular population, it can be really important for the transference of the patient, right, to know that the clinician is a mother, and has sat where she's sitting, so to speak.
And why do you think it's important? Because I guess you're talking about trying to get a positive relationship so somebody feels that they will trust you, and so that they can feel the vulnerabilities that maybe they're not allowing themselves even to feel, but certainly not allowing them to feel with another person. So sort of from your experience, why is it important for the patient to be able to know a bit about you?
Well, I think it's important for them to know that you're a mother, because there's a certain type of love that a parent has for a child, right? That is different than other types of love. And it's one of the hardest things you will do, right, is become a parent.
Right.
And you can't really know what that's like unless you've actually lived that experience.
Okay.
So you can read all of the books you want about sleep deprivation, right? Or giving birth, or having anxiety that something's going to happen to your newborn, right? But if you haven't had a child, you can't really even get close to understanding the complicated feelings that can bring up, and the ambivalent feelings that can bring up.
And are we talking here only about mothers who've given birth, or are we talking about parental attachment and parental focus?
It's both.
Right.
It's both. I in our practice, we see a lot of women who've had birth trauma.
Yeah.
So there's that subset. We see, unfortunately, a lot of women who've lost their babies.
Sure.
And then we see both mothers and fathers who have just adjustment or transition difficulties to parenthood.
Yeah.
And it doesn't need to be that you birth the child yourself, right? I mean, we certainly see adoptive mothers all the time. But there's the unique about being a parent, unlike, you could study alcoholism and not necessarily have to be a recovering addict to treat it.
Yeah.
Addiction,
yeah.
Right?
No, I get it. I mean, I sort of, I was telling you before the show, and this is my disclosure. I have a boy who's just turning 11 soon. I'm not his genetic father. He came into my life. I'm very grateful for it about 5 years ago. And myself and his mum, we don't have that relationship. We've become friends. We're good co-parents. And Matthew and I decided to continue having our close familial relationship. And again, I'm really grateful for that. My experience is it's very different to any relationship I've had with anybody. Having this child in my life is, it's transformative, and it's terrifying at times, has to be said.
It's absolutely terrifying. It's like wearing your heart outside of your body all the time.
Yeah, I do things like I might be watching some sort of disaster movie, which before having Matthew in my life would have just been entertaining. Now I'm like going, oh my God, if Matthew was in there, I'd be having to do this and that. And then I go, calm down, Noel, it's fine. He's not in that. And that was never the dialogue I had with myself sort of in the past. It would just be, no, it's just an entertaining film. But I've killed many people in my head who I thought might threaten him, which I never thought would happen, but there you go. So I guess it is. It makes me think of, the work of, I'm trying to think of a family therapist name. He wrote Children of the Slums from his work in South America. And his essential point was that he was a psychoanalytically trained psychodynamic therapist who did family therapy more than anything else. But he rewrote the book in terms of understanding. It'll come to me at some point. My brain works. Sorry?
Minuchin?
That's it. There you go. And just his idea that familial relationships are things that are chosen, negotiated between people. And it's got nothing to do with genetics or biology necessarily. It's the human relationships, which is the core point, I guess, that you're making, that you want to get to that human relationship.
And there's a lot of, being a parent, right? There's the biology, there's the genetics, there's the day-to-day, right? There's all kinds of ways to become a parent.
Yeah.
And a lot of what happens in therapy is reparenting of oneself, right?
Yes.
And so it's the holding, and I think this is part of how at least personally, I was affected by the pandemic in terms of work, is that the holding, so to speak, I don't mean physically touching anybody, but the holding of the environment, the space for the patient, suddenly had to switch overnight from something that was normally in person to a screen, right? And
Yeah.
how and the translation of that was difficult for me. But for sure, I mean, parenting is not about biology.
Yeah. Yeah. I mean, there can be components of it. But that thing, I'm really interested in how the profession has shifted. I mean, I've done sort of screen-based stuff all my therapeutic career, as long as it's been available. And before that, you know, more broadly telehealth and approaches. So mostly because I work internationally and all that sort of stuff. So it was a pragmatic thing. But it's also, I was influenced by the work of things like the Samaritans, which have always been telehealth based. I don't know if you know the Samaritans in America, but they're a sort of mental health charity that help people who are suicidal, and they've been going for donkey's years and saved many lives, and they've done it over the telephone all the time. So it's clear, but it's also, I think, you know, telehealth was also good at increasing the franchise in terms of mental health, particularly, say, for single mums who might not be able to get out the house. But if you can do Zoom, great. Or if you can do Skype prior to that, or just be on the telephone, you know, you were sort of reaching out and making it sort of more accessible. So I'm a great fan of it. But our profession went overnight online.
Yes.
And you know this, but other people don't. There has been a debate about telehealth raging sort of for a million years amongst therapists, people in various camps and stuff like that. And that stopped overnight because of the pandemic. And like, I think largely the debate is over, and now people are just talking about what's the combination, what's the mix that works for them. But as a psychodynamic therapist, I'm imagining it was really quite a challenging thought for you. Like, I don't know, had you had experience of doing online stuff before?
Not at all. No.
Wow.
No. And so, yeah, overnight we figured out how to do it.
Right.
Just like everybody else, right? But as soon as, I mean, I'm seeing as many patients in person now as I can. It's definitely what I prefer. It feels so much better.
Sure.
For me.
A lot of communication cues are, or how we understand each other, are non-verbal, you know, contextual, smell, sound, all of this. And I think particularly in terms of talking about parenting stuff, there's a lot of kinetic memories in people.
Yeah, and grief work and trauma work is really hard to do. Not in person.
Yeah. So, but you survived. You got through. You've managed. You're at this point now, and then you're sort of working with people that have challenging experiences of becoming a parent themselves. And generally, you talked in quite technical terms about there's a presenting range of anxiety disorders. What does that look like on human terms? So if somebody's listening who isn't trained, what might be the things and feelings and thoughts that they're having that might make you think, oh, well, let's have a chat about that and see if we can talk a bit more about it.
Yeah. So, I mean, usually by the time people get to us, they have been referred by their OB or their psychiatrist, or a doula or a lactation consultant. So we see really women across the reproductive lifespan, but primarily, so if you're suffering from fertility challenges, we'll see you. if you've had miscarriage, a stillbirth, loss, any kind of neonatal death, and then anything that happens in the pregnancy and, up to 2 or 3 years postpartum.
Yeah.
So many women develop mood disorders in pregnancy.
Yeah.
And then in the postpartum period, you can develop anxiety or severe depression, severe anxiety, right? Psychosis even.
Yeah. Yeah. I mean, people don't understand that psychosis is pretty common sort of thing. Sort of like talking about the during pregnancy stage, because there was, when Meghan Markle came out and said, I struggled during that phase and had my struggles diminished by the people around me. I was told that they weren't serious. My understanding is that that's pretty common, and that we need to address that particular issue, really, because how common do you think it is for women who are pregnant to experience some sort of either depressive or anxious sort of experiences that might be clinical in nature even?
Oh, it's 20%.
Right.
Right. So, and actually I was going to share with you the reason I got into this specialty is because I got pregnant in graduate school intentionally. Yeah. And had a child, my first child, right after I graduated when I was in my postgraduate training, and I had a traumatic childbirth with him. And I had undiagnosed hypothyroid disease.
Oh, right.
Which looks a lot like postpartum depression.
Yeah, absolutely. Yeah.
And so for 6 months, I was walking around feeling horrendous, telling my doctors, nobody was listening. They were kind of just blowing it off as postpartum depression, but not ever giving me a blood test.
Yeah.
And what's really interesting about that is that hypothyroid disease is really common in the postpartum period. Yeah.
It's got to be. I mean, all your glands will just go, what have you done?
Right. So there's the kind that is temporary, and then there's the kind that is a disease and stays with you for the rest of your life. I had the kind that stays with you for the rest of your life.
Thankfully, you got it diagnosed, because it's a nightmare.
I did, but this is why I decided to specialize in the field, because in Philadelphia, right, the 5th largest city in the US, I had to beg 6 months postpartum to get a blood work, to diagnose myself. And of course, as soon as I started taking the medication, all my symptoms went away.
Yeah, of course. That's right.
Because it was an endocrine problem, not a...
I just want to say to anybody who's listening to this, if you're not automatically offered a blood test when you get a diagnosis of anxiety or depression, the person giving you that diagnosis doesn't know what they're talking about. You should always be checked for physical substrate.
Right. You have to rule out the medical.
Absolutely. And particularly at the moment with post-viral stuff, and we're getting people inappropriately diagnosed with depression when they have post-viral syndrome, and the potential for chronic fatigue. And that's medical. That's not psychological. And actually, if you treat that psychologically, you cause more damage than good. And it's really important. I'm really pleased you brought that up, Perri. It's like, particularly I think in old school psychodynamic, psychoanalytic thinking, the notion of biology was completely denied.
Right. Well, they kept sort of saying you're having a psychosomatic reaction to a traumatic birth. And I kept saying, no, I'm not. Something's really wrong. Yeah. But anyway, in that process, what I found is that there were no groups for women who had just had babies. And there was only one clinician at the time who was treating new mothers in the 5th largest city in the US. And so that's why I decided to specialize in maternal mental health.
Great. I'm glad you did. I love when people can turn around a challenging life experience into something that is creative and positive and flips it. It's a sort of transformation. Are you like that in general? Is that how you approach life? You sort of go, right, I'm going to turn this around and make it, or was it just one of those things?
I wouldn't say that was like, well, it was a pivotal moment in my career, I guess. Yeah, I mean, I feel really fortunate to have had that opportunity, and we now run groups, virtually now, but also across the city, for new moms, and there weren't any.
Just thinking about these things, and sort of this comes with, again, a health warning. We're going to have a conversation maybe about the context that you're in, and the impact. I mean, you talked about sort of having a traumatic birth experience. And again, I don't think people understand just how common that is, with our sort of largely sort of factory birth system that exists, hospitalized factories that are a bit, a bit like abattoirs, to be honest, if you like. But I mean, I think, birthing systems are improving and have been improving since this dinosaur was born. But still, it can be quite a traumatic experience for a lot of women. How many women do you think do have, a sort of traumatic experience of birth?
I actually don't know what the percentage is, but there's a lot of problems in the US. I mean, there's some amazing doctors here, and some amazing midwives, and then there are some people who just do not listen to women.
Yeah.
One of the things that I created in my practice is a tool to help providers prepare their mothers,
Right.
their pregnant patients for the postpartum period.
Yeah.
Because everyone's so focused on the birth. And then what happens is that the woman gets really attached to how she's going to birth this child. And when that doesn't go according to plan, and often it doesn't, right? That in and of itself can be traumatic.
Yeah.
And then there is real trauma, right? There's little trauma, and then there's the capital T trauma.
Yeah.
But we spend a lot of time educating providers, and also working with our pregnant population, to figure out what they need to advocate for themselves, so that to minimize the trauma, really, and to also process whatever old trauma they're coming in with, so that they're not confounding each other.
And I guess there might be something to be said about the fact that these types of experiences may happen and probably going to continue to happen, and it's really important that people open up and talk about it, because I think historically, I mean, there still is a sort of very much a Christmas card decoration image of what's going to happen to you, as opposed to, I don't want to frighten people about the possible outcomes, but it's pretty common, it's often happens that you have a challenge during these times. And as you and I know, the sooner somebody's experiencing challenge can say that, can voice it and get help, the sooner they're getting the sort of resilience tools that they need to reduce the damage to themselves. I guess.
Correct.
So absolutely. I don't want to frighten people and say, if you're pregnant, listen to this, and you're listening to Noel and saying, you're going to have a terrible time. No. That's not what I'm saying. What I'm saying is help-seeking behaviour, which comes from good knowledge about when something is right and when something is not right, is absolutely crucial for health and well-being. It doesn't stop you from having bad experiences, but the evidence shows that it will reduce the severity of that. I mean, you get help sooner, etc., etc. That's, I guess, what I'm talking about. You're nodding away with me.
Absolutely. But it's for sure that, and it's also not being so attached to how the baby is born,
yes.
Right? And not spending all of your pregnancy focused on like what you're going to pack, in the hospital suitcase, right? But rather how are you going to actually take care of the baby when you get it home?
Yeah.
Right. And how are you going to take care, more importantly, how are you going to take care of yourself, right, when the baby comes home?
Well, let's talk about that, because put the oxygen mask on yourself first. That's where you start with self-care and protection of self, because I just literally did it today. I pulled out of a commitment that was draining me, and I don't have the resources to give to it, and I'm not going to overstretch myself. I'm going to look after myself and do self-care. So can we talk about that, this idea of you know, a mum or a dad giving themselves permission to exist as a needy human sort of at that time?
Yeah, it's a really hard one, because I mean, women in particular have there's a lot of mommy myths, right? There's a lot of societal pressure on what it means to be a mother and what that's supposed to look like and how you're supposed to feel about yourself and your baby. And there's a lot of guilt and sometimes shame, often shame, that comes along with that. So, you know, for us, and that's why we created this tool to help women with a healthy pregnancy prepare while they're pregnant, right? For how are they going to take care of themselves in the 4th trimester when the baby's home.
Yeah.
Really
can you share some of your ideas now? I don't want to put you on
sure.
Sometimes
no, it's
my brain
on my website. It's on our website. You can download it for free.
So share some of these ideas that you have to help people think about these things.
It's actually literally just a tool for the doctors and providers to hand the pregnant woman, assuming she's, you know, gets to the 3rd trimester with a healthy, normal pregnancy, to get her to think about, like, how is she going to get fresh air? How is she going to sleep? Who can hold the baby so she can sleep? How is she going to get some movement, some exercise, right? Who is in her, who can she call if she's feeling really, really anxious or really scared or really tired, right? What are the groups in her community that she can go to so she doesn't have to research anything in her sleep deprived postpartum state, right? But it's all written out prior for her provider's number, her therapist number, right? Who can bring food over, like preparing all of those things so that she can set herself up as best as possible.
Yeah, brilliant. I mean, in the UK, we have this thing called the NCT, the National Childbirth Trust, which provides groups and people sign up for it. It's a not-for-profit organisation that is funded and provides these groups. Is there something similar in the US, or is it more down to individuals just having the initiative to find?
No, unfortunately, nothing is really, in terms of maternal mental health, nothing's really funded here.
Yeah.
And that's a huge problem. And we could probably spend hours talking about that.
Yeah, I mean, what's immediately coming to mind is some of the changes that Obama made to healthcare in the US, and a lot of that was focused on trying to sort out this issue around maternal healthcare.
And then Trump pretty much changed all of that.
Shat all over it, really, but he did on everything. So, and that's unfortunate. It's just unfortunate he was incompetent and unpleasant from our perspective.
Yeah.
So when you've got somebody who's both of those things, it's sort of like allowing a child to take responsibility for a very expensive yacht. We all know how that's going to end up, really. Sunk somewhere. But I guess without getting into that too much, I mean, it must have been, I imagine, I mean, it was frightening enough this side of the pond. I can't imagine what it was like when you were actually on the yacht as this child was seemed intent on killing you all. But I'm wondering about that. I mean, we talked about the impact of external factors on their relationship with the therapist, and what then comes into the room and how your role might shift. Were similar things happening around that in terms of the work as a therapist and what you were having to support, I guess, in terms of your patients and clients?
Sure. I mean, you know, particularly for women who had experienced trauma or any kind of rape or sexual assault, when Trump became president, that was almost like a re-traumatization.
Yes.
For a lot of them, or for most of them. And the message, the unconscious message was, you know, what happened to you didn't really matter. Right. And that was extremely triggering for so many women in our practice, the majority. And so holding people through that grief, that extra grief, sometimes the secondary trauma, right, of having a president elected who was so fundamentally was fundamentally misogynist, really. That was, I guess, the other experience that I've had as a clinician where, you know, I was really mourning the same thing that most of my patients were mourning.
Yes, I understand.
Yeah, so that was really powerful.
Yeah,
and a very helpless feeling too, because unlike, you know, what we work on in individual therapy, I mean, this was an external factor, right, that was going to affect every single person's day-to-day life, and for the next at least 4 years, plus, right, because the reverberations last forever. And there's very little control that the patient can exhibit at that point, right?
Yeah, I mean, I don't want to politicize this conversation because it's about therapy and it's about helping people, but it's also about reality. So, you know, one of the things that I've been uncomfortable in therapy historically has been when it tries to deny that there is an external reality. So if I think about things like, I'm actually thinking about Mnuchin. I saw some old video of Mnuchin doing some, it's only old because he's so old himself, some video of him doing some family therapy stuff. And it was clear in the video to me that the husband was a controlling narcissist, horrible person. And that was not challenged at all. He was just simply looking at the relationships between people, which is very old practice. These days, as a family therapist, if I see disturbing behavior that looks controlling and by a guy towards a woman, I'm going to stop the work and I'm going to make sure that she's safe. I mean, that's the way it works these days because we don't deny that reality. So things have moved on and things come into the room. And that's really what I'm talking about, not a party political thing or a policy thing. You have whatever views you want, as long as they don't put you or other people at risk, you know. But as a mental health professional, I'm saying if somebody comes in and they have delusional states that put them or other people at risk, I have to take action. So people should know that. But this is stuff that directly generates material. And more than that, I mean, there's research that was published in the media over here in England today, looking at sexual trauma on women and the lifelong impact. And people tend to think of it as sort of it's an emotional, psychological thing, but it's not. It's physiological, and psychological is physiological. So there are certain things that happen if you've had sexual trauma in your teens, such as calcification of your arteries, which doesn't happen if you don't have it. And so you're more at risk of heart attack because of the calcification, because you've had a sexual trauma. And most people don't know that's literally what happens. Trauma has a huge physiological impact, and it increases your risk of all sorts of things, not just feeling unhappy about yourself, which is, I think, what people sort of understand. And we're clearer and clearer now because trauma has what's called an epigenetic impact. So it changes your genetic structure.
I think you'll find this interesting too, outside of epigenetics, but unconscious, right? Like what's passed down generationally, right? Transgenerational trauma. And just even in my life, it's really fascinating because I didn't realize this until 2 years ago. My mother had a stillbirth after she had me. And I was not quite 2, but I was pretty precocious apparently. And I think she had the stillbirth when the baby was about 7 months. Anyway, and then she went on and had another kid, my younger brother, and I would walk around telling people, although I don't remember this, but I apparently walked around telling people that we were supposed to be 3 babies, but 1 died.
Wow.
And the other thing that's really fascinating is that my mother had a C-section
Yeah.
with me. And when they cut my mother's belly open, they cut me on my face. And I don't know if you can see it, but I have a scar that's visible, pretty deep.
Right.
So anyway, it wasn't until 2 years ago, right, after I've, been in practice for almost 20 years, doing birth trauma work, that I realized that there was probably a very large unconscious process at play, that brought me to this work, around birth trauma and loss.
But I think that's got to be true for sort of motivations for most human beings about what brings us. I think there is something about the nature of humanity that we're looking to work through whatever these issues are, in our choices. And sometimes it's repetition, sometimes it's working through, etc., etc. But we're always on that journey, I think. In terms of the transgeneral transference is a long word, and I'm going to try and explain it to people as my understanding. You correct me if I'm wrong, but what we're talking about there is the encoding of experience, but not as knowledge. It's experiential, and it can be repeated because it's experiential and not based in knowledge. So some people call it the unknown known. And one way of that transference, we know it's not made up. So we know, for example, that the amygdala, which is a bit of our brain that processes fear and looks at fight-flight reactions, can encode to pass on information to the next generation. The reason for that being that if we had to explain to our children every single thing that was going to kill them, they'd be dead. And so there has to be a sort of an automatic system somewhere. And the classic studies that were done were obviously around upsetting animals, because they always are, but there's the classic study that demonstrated, I'll very briefly explain it to people. So there were 2 pregnant rat mums, and they knew that in utero, one of the sets of fetus rats had developed the amygdala and the other set hadn't. And they exposed both pregnant mothers to a frightening event plus a specific sound and smell that went with that frightening event. And they exposed her several times, so that she was really terrified. It's horrible, sort of what we do to animals. And then they went to birth. And then postpartum with the baby rats, they exposed the 2 groups to the sound and the smell, not the event. And the ones that had the amygdala ran around terrified. So the ones that had the development of amygdala in utero ran around terrified. So that mum had passed that information on to them genetically. And the others didn't. They didn't run around because they're amygdala. So we know it's physiological, biological stuff. Sometimes it sounds almost sort of Jungian, transpersonal, godlike stuff that as therapists talk about, but it's not. These things happen because we are fundamentally social animals.
Right.
Fundamentally connected. And as herd and social animals, we have these incredibly subtle and complex ways of passing information to each other, and particularly around emotional genealogical lines.
Yeah, and in terms of race, right, we see that a lot too. And in certain populations, right, where it's just passed on from generation to generation. And in terms of maternal mental health, and mortality, and taking care of Black mothers or brown mothers in this country, we're seeing that a lot, right? And a lot of that comes from just pure racism, right? And what's been passed on generationally.
Yeah, absolutely, without a doubt. So when we're bringing in these sociological experiences, folks, it's not because we're making political statements, it's to understand that as human beings, we're impacted upon by all of these things. And I think it's only, to be honest, I think it's only ethical of therapists to acknowledge that reality. Otherwise, I think we end up blaming our patients for their experience and telling them something wrong with them, as opposed to, well, I sort of understand why you're reacting like this. It makes a lot of sense given X, Y, and Z. Now let's do something about it.
Right, but it also, you know, reminds me that you have to try to understand their culture, right? And where they come from.
Yeah.
And that means their religion, right? Their socioeconomics, like the family history, right? That's all important. And all of those people are in the room. You asked who's in the room, right? All of those people are in the room with the patient.
Yeah.
Right.
I guess all those people are in the room if we allow them to be there, and that's my point about the work that you do, because it seems to me you have the capacity to allow those others to be present, and it doesn't faze you or frighten you, that sense in which there might be a lot going on.
Mm-hmm, mm-hmm. Yeah, but it takes some real listening and digging to understand the whole person in their environment, right? And the context, and how that is playing out in what they're presenting with.
Sure, which means opening ourselves up, I guess. And I suppose it comes back to that thing about, you know, coming back to the early conversations we had at the beginning about what do we share and what don't we share. And I don't have hard and fast rules, but I guess for me, it's like this: is it useful or not? Is it going to help the person sitting in front of me to explore something, if they can understand something about me, or will it hinder them? And I'm not sure I get that right, like all the time, no way, but I give it a shot. And there's something about, I guess people pick up on the fact that at least I'm trying, and that's important. It feels like somehow you're important because I'm willing to take that risk myself.
Yeah, the question, I mean, unless it's like, you know, a very obvious question, right? The sort of like, I mean, the question I always ask is, I always ask to the patient is, you know, what's behind your question? I'm happy to answer it, but why? But really, what is it that you're trying to figure out? Because often it's not that they really want to know the answer to the question they've asked. It's really about them and something else, and their transference to you that they're trying to figure out.
Yeah.
So often you don't even have to answer the question.
Yes. But there is something, I guess, thinking about this idea of being able to, and you talked about hold, and hold as a concept, as an emotional space, that you can hold this idea that there's something behind what's being said, that there's a meaningful communication there. And I may not know what that meaning is, but I'm willing to try and find out with you. Yeah,
that's really important, I think.
Yeah.
I try to approach it like this. If I'm confused, I say to myself, this person's trying to tell me something. I just don't know what they're trying to tell me. Yeah,
absolutely. And in general, because we're sort of getting towards the end of the show, we haven't finished that, but we're getting towards it, and it's sort of moving in the direction of looking at sort of, you know, practically what you offer to people, how they get hold of you, and what the services are, et cetera, and who can come to you, and all of that sort of stuff. But in general, sort of how often or how long or how regularly do you see somebody? Is there a specific set of circumstances, or does it vary very much?
It varies. But I see people every week. The sessions are 45 minutes long, except for the first session is longer. You know, if they're coming in because they had a traumatic birth and they just want to process the birth, but the baby's healthy and they're healthy and there's not any history of anything, you know, that could be brief treatment, right? That could be, I don't know, 3 or 4 months.
Yeah.
Other than that, the average seems to be about 2 years, and sometimes longer. But again, I'm doing psychodynamic work, so it's not just about what's happening in the present, right? So the treatment tends to be a little bit longer, but I'm not in my practice and what I tell the therapists that work for me, I'm not in the business of keeping people in therapy for 20 years.
Yeah.
I really think it's important for people to come and get the skills and then go try it out without their therapist. They can always come back.
Yeah.
But knowing that you can be efficacious without a therapist, I think can be an important part of the journey too.
Yeah, I mean, I guess what you're saying is that you're not necessarily there just to treat people with sort of mild depression or anxiety and, to process them through. I mean, we have systems here with, if people present at that level, they can get relatively quick interventions that are going to be very effective, but it's where other issues have come up. And so somebody's generally processed through a system to reach you. 2 years doesn't seem particularly long to me. I'd have said 2 years, and generally I would say 2 years. And the reason I base it upon that is some early psychodynamic thinking about the formation of mind. So the first 2 years postpartum is when mind forms in sort of psychoanalytic thinking. Anyway.
Right. Well, I was thinking more for the specific population that we see, because what's so beautiful about the work that we do is that the women get better.
Yeah.
Right. It's not like chronic depression. Right. And then what happens is if they come in for IVF because they're going through fertility treatment, then they get pregnant and they come back, and then they, decide they want to have a second baby or a third baby, and they come back to prepare for the postpartum period for that. Right. So we often see them across many, many years, but the average length of the primary treatment, the first time we see them, will usually be about 2 years. But then we might see them back again, right?
I guess my point about long-term work, and I think you probably would agree with this, this way of working is that, whatever somebody presents with, there's generally such a long backstory that is in them, that story needs to come out and be processed, so that when they've done that process, actually it might be lots of intergenerational stuff has gone, meaning it's never passed on again. And so there's a sense in which there's a full stop to a lot of things, and very much a new beginning, whereas a lot of shorter term therapies, which are amazingly effective, I'm not putting them down, so CBT, DBT, etc., focus much more on skills acquisition, which is brilliant. And I think a lot of psychodynamic thinkers are bonkers by not doing that, because we're not in the regressive stage with patients anymore. We don't have highly bound sort of egos from, Viennese waltzes that we're dealing with, that Freud dealt. That's not what's happening anymore. Mostly we're talking about people with ruptured egos and not enough skills. That's what we're talking. And so giving people positive skills is a bloody good idea, and I fail to understand, but that doesn't mean that even when people don't have a lot of ego material to work with, that they don't have a lot of stuff that is in here that needs to be processed, and so these methods, I think, are absolutely crucial, to be honest. So I think to put it in American terms, you get a lot of bang for your buck if you do this type of work. Okay.
Yes. I think it's super important, and it's life changing. I mean, and
yes.
If we're not here
it's generational changing, because it means the next generations, and particularly in the area that you're working, which is, we're talking about generations. We're not talking about individuals. We're talking about systems. Somebody comes into the practice, there's a whole systemic problem that has been forced on them for some reason, and it's that systemic problem that needs to be unpacked and sorted out, understand what you can do, the whole generational stuff, so that it can just stop, and they can just be a mum or be a dad with a kid, and do the best that they can.
And if you treat, as if you treat one person in the family system, you can change the whole family system.
I mean, that's, like, I hope people understand that that's bog standard these days. That sort of treat the person who's complaining that they've got a problem, and then you just do so many fantastic things. We are at the end, just about at the end of time. So some quick information about how people get hold of you. What's your website?
wholeheartmaternalmentalhealth.com.
And we will put that up for people. You're based in Philadelphia. Do you only take patients in the US? I know sometimes it's difficult because of insurance stuff.
Yeah, so we can only take people in the states that we're licensed in.
Okay.
So we're licensed just in Delaware, New Jersey, and Pennsylvania.
Brilliant. That's useful to know. And I presume because you're American, you take loads of insurance companies and all that sort of stuff.
No, actually,
No?
we're private pay. The
Okay.
big, we can have that talk some other time, but there's a big.
No, I don't want to go into the American health funding system. It's like, you'll see my head explode. I don't want to go there at all. So it's private pay. People need to be able to pay. Okay. And I think we just are at the end. I think we need to stop there. Perri, it's been fantastic to have you on.
Thank you so much.
Well, I haven't had such a great, interesting, stimulating conversation in ages, actually. So it's good to meet a fellow traveller and sort of really, if anybody's listening in those states, you need help, this is who you need to go to, really. We didn't talk about some of the other things, so maybe come on another time, because I think we do need to talk about some of the other issues that are causing trauma for women's health at the moment in the US, and the attacks on sort of
abortion rights.
Jews, and we didn't get onto that, but I think it is important. So, but we're going to finish there. You stay there with us, Perri. I'm going to say goodbye to everybody, and I shall see you all next week. And it's Annie, I think, next week. Annie McCulloch, I do believe. I've just remembered a guest. I never do that, but Annie is a regular, so I'm looking forward to seeing her, who's also in the States. So we're having a sort of cornucopia of Americans, which is great. See you all next week. Bye-bye.